Greetings and welcome to the e-learning course on a public health approach to addressing female genital mutilation. This is Module 1, Session 1. The objectives of this session are to know how to define female genital mutilation and the medicalization, to learn about the different types of FGM, to learn about the epidemiology of FGM and the medicalization of FGM, to learn how FGM violates several human rights principles and codes of professional conduct, and to understand why FGM is a public health issue that requires a public health response involving the health sector. The presentation today will be structured around these different objectives. First, we will talk about the definitions of FGM. Then, we will discuss the different types of FGM and the subtypes, the epidemiology, how FGM is a harmful practice and a violation of human rights and professional ethics, and why FGM is a public health issue. Female genital mutilation comprises all procedures that involve the partial or total removal of the external female genitalia or other injury to the female genital organs for non-medical reasons. The World Health Organization classifies FGM into 4 different types with subcategories according to the severity of the tissue removed. Type 1 FGM is the partial or total removal of the clitoral glands. This is the external part of the clitoris, and/or the prepuce, which is also known as the clitoral hood. This is the skin that surrounds the clitoral glands. There are 2 subtypes, depending on whether the clitoral glands is removed, with or without the removal of the clitoral hood. In type 2 FGM, the labia minora are removed with or without removal of the clitoral glands, or the prepuce, and with or without removal of the labia majora. There are 3 different subtypes of type 2, type 2A, type 2B, and type 2C, depending on whether the labia minora alone are affected, whether it's the labia minora are removed in conjunction with the removal of the clitoral glands and/or the prepuce, and whether or not the labia majora are also removed. In type 3 FGM, there's a narrowing of the vaginal opening with the creation of a covering seal, which is done by cutting and appositioning the labia minora and/or the labia majora, with or without removal of the clitoral prepuce and the clitoral glands. Type 3 is also known as infibulation. There are 2 subtypes, depending on whether the labia minora or the labia majora are affected. Type 4 FGM includes all other harmful procedures to the female genitalia for non-medical purposes. This can include pricking, piercing, incising, scraping, or cauterizing. Now moving on to the epidemiology of FGM. There are more than 200 million women and girls alive today who have already undergone the practice. This is from population-based studies from 31 countries. There are also an estimated 3 million girls who will undergo FGM each year at the current incidence rates. And FGM is a practice that's mostly performed on girls between the ages of 0 and 15 years old. FGM is a deep-rooted practice, and there are many reasons why girls are subjected to it. It is a social norm. Many people believe that it prepares girls for adulthood. It can be considered a rite of passage in many places, to move from childhood to womanhood. It's also considered a way to maintain family honor and to reduce the risk of premarital sex and to increase marital fidelity. Some people believe it will increase the marriageability prospects. It's also done to promote femininity, modesty, and cleanliness, and some believe they're following a religious custom by performing the practice. Over the past 30 years, we have seen a marked decline in the prevalence of FGM. If we look at the prevalence rates among girls aged 15 to 19 years old 30 years ago, we can see that about half of them, in the countries where FGM is practiced and we have data, had undergone the practice. Now that number is down to about 1/3. So we can see in this graph the trend over time decreasing. In this slide, we can see decreasing prevalence rates over time. The areas that are in dark blue are the areas with the highest prevalence of FGM. So the image on the left is 30 years ago and on the right is today. You can see that those areas in dark blue are actually shrinking. What do we mean by the medicalization of FGM? WHO defines it as situations in which FGM, which includes reinfibulation, is practiced by any category of healthcare provider, whether in a public or a private clinic, at home or elsewhere, at any point in time in a woman's life. So as you can see, the act of a healthcare provider performing FGM qualifies it as medicalized FGM. Now let's be clear, WHO opposes all forms of FGM, regardless of who performs it. There are many reasons why healthcare providers perform FGM. They are often members of societies in which FGM is a social norm. Some actually believe there are benefits of FGM. It's often done to satisfy the demands of the community. They may do it for financial reasons. And some believe that there is a harm reduction if they do FGM as opposed to it being done by a traditional circumciser. And in some countries, FGM is not actually forbidden by the law. This slide shows the prevalence of medicalized FGM. These are the countries that have the highest medicalized FGM. Egypt and Sudan both have high rates of medicalized FGM, with more than 3/4 of the FGM being performed by healthcare providers. There's also high prevalence of medicalized FGM in Guinea, in Djibouti, in Kenya, Yemen, Iraq, Nigeria, and Indonesia. This slide shows who is actually performing FGM in the countries that we saw highlighted in the previous slide. So these are the countries with the highest rates of FGM medicalization. The dark purple indicates when the practitioner of FGM is a medical doctor. The light purple is when it's a nurse, midwife, or other healthcare provider. And the orange is when it's a traditional practitioner. So we can see that most of the FGM is performed by medical doctors in Egypt. In other countries, it's done by nurses, midwives, or other healthcare providers, or by traditional practitioners. Let's be clear, FGM and its medicalization have no benefits. FGM as a practice only causes harm, even when it's done by a healthcare provider. FGM is also costly to the health system. It violates the professional codes of conduct and ethics of healthcare providers, and it's a practice that violates human rights. There are many health risks associated with FGM, so women who have undergone FGM are at a higher risk of many gynecological, obstetric, urological, mental, and sexual health complications. There are also risks to girls immediately after the practice is performed. There may be excessive bleeding, there may be infections, and sometimes FGM can even lead to death. We'll have more details about the different health risks of FGM in a subsequent module. FGM is also costly to the health system. All of the health consequences of FGM come with healthcare costs. Now, we did an analysis at WHO on the economic burden of FGM in 27 countries where we had data in which there was a high prevalence of FGM. We estimated that it costs health systems $1.4 billion per year to treat the health complications of FGM. And this slide shows what would happen if we did nothing. If the current incidence rates of FGM continued at the same rate, we would see these costs, in fact, continue to rise to 2.1 billion per year in the next 30 years. If we reduce FGM completely and we move to a full abandonment model, we can see that we can drastically decrease the spending on FGM complications to the health system over the next 30 years. So while FGM is a human rights issue, it's a public health issue, it also comes with high economic costs. FGM medicalization violates professional codes of conduct and the principle of do no harm. It's also a violation of several human rights principles. It violates the right to health, the right to be free from violence, the right to life and physical integrity, the right to non-discrimination, and the right to be free from cruel, inhuman, and degrading treatment. FGM is also a public health issue that requires action. As we saw, it affects millions of women and girls. We saw it affects their health as well and is associated with a higher risk of a number of health complications. FGM brings high costs to the health system to manage the complications. There is an increasing trend in the involvement of healthcare providers in the practice, and we saw that it violates several human rights principles for women and girls. To conclude, medicalized FGM must be stopped. FGM has no health benefits. It's against the professional ethics of do no harm. When healthcare providers are involved in the practice, it only further perpetuates it by giving their endorsement to an unsafe and harmful practice. Even when FGM is misinterpreted as harmless or safe, it still causes harm. This concludes this session, and I thank you for your attention.